Okay, hi, welcome everybody back from break. I'm Colleen Kelly, I'm from Brown University, Providence, Rhode Island, and I'm going to serve as the moderator for this second plenary session. We have a lot of good talks ahead. The title of this plenary is Fecal Microbiota Transplantation. And our first speaker that I'd like to introduce is Gianluca Iannero. He's at Gemelli Digestive Disease Center in Rome. He's published extensively and is an expert on FMT and C. difficile and has led several international consensus conferences on the subject. He was actually named a UEG Rising Star in 2020. He's going to speak to us today on the efficacy of FMT. Does engraftment matter?
Thank you, Colleen, and thanks the Gut Microbiota for Health for inviting me. This will be the only one slide that I will spend on FMT and Clostridium difficile because this is well established. FMT works very well in Clostridium difficile infection. We have more than 80 to 90% efficacy rates, and well, there are several difficulties, the bureaucracy, the stool banks, and whatever, but it clinically works. But have you ever asked why? Basically, it works because on an ecological point of view, because C. diff is a model of acute, simple dysbiosis. As you can see, if you see the microbiota profiling of a patient with Clostridium difficile infection, you will see a huge drop in microbial alpha diversity, both in the level of OTUs, so the richness, and in the Shannon index, but also a loss of similarity within the different patients, so a disruption in the beta diversity. Moreover, beyond the ecological parameters, you have also the change and detrimental change in the human gut microbiota with the persistence of aggressive and pro-inflammatory bacteria and a decrease of beneficial taxa. Well, FMT, when transplanted to other kind of disorders or to chronic non-communicable disorders, has not replicated the same satisfactory results that we had in C. diff. And we have several examples in ulcerative colitis, in irritable bowel syndrome, in metabolic syndrome, and so on. But why? This is an ecological response because chronic dysbiosis is much more difficult to be restored than an acute dysbiosis. So, how we can improve the efficacy of FMT in the other disorders beyond CDI? One of the most important matters that have been already discussed in this Congress today was the microbial engraftment. Basically, there are some studies that show that microbial engraftment is associated with a clinical response. In the very early phases, we had evidence that the responders to FMT have a microbiota much more similar to the donor after FMT, so they had a microbial shift. And later, with the Nicola Segata group, we demonstrated in a metagenomic meta-analysis that regardless of the clinical condition, the strain microbial engraftment is basically associated, is significantly associated with the clinical response. Anyway, there was another metagenomic meta-analysis published in the same issue of Nature Medicine by the PFBOF group that showed that the microbial engraftment is not associated with a clinical response. Well, Harry Sokol and Agus Lavelle, in an editorial, told that this disagreement may be due, as it happens in every meta-analysis, by the different studies included and the different approaches for definition of the engraftment, tracking and modeling strains, and the community dynamics, basically. And I agree with this kind of interpretation. So, how can we define the donor-recipient microbial engraftment? In the early phases, when we had not studies with shotgun sequencing, it was just a matter of beta diversity. In this paper from Paul Moyedi, the responder had basically a microbiota that was more similar to the donors rather than non-responders. Anyway, the microbial strains are generally unique to specific individuals and are rarely shared between unrelated individuals. So a beta diversity-based approach could be not so precise. So we identified another kind of approach to defining engraftment, so a strain-based definition, and it was much more precise than beta diversity in defining the relationship between the donor and recipient after FMT. In our view, the donor strain engraftment could be expressed as a fraction of newly detected donor strains after the FMT in the recipient versus the retained recipient strains that he had before the FMT. Microbial engraftment can be affected by several factors that can explain the different results by the two meta-analyses. First, the target disease. We have shown that the patient with the chronic non-communicable disorders are less likely to be engrafted and then to be cured by donor microbiome rather than those with acute infection. This data can be interpreted in several ways. Probably there is an ecological way to address it because a chronic dysbiosis, as I told you before, is less likely to be cured than an acute dysbiosis. Another issue is that most of the people that had infectious disorder take antibiotics before, and we identified, as I will show you later, that antibiotics can improve the microbial engraftment. Another point is the diversity at baseline of the recipient. In this paper from the Nudo Club, people with metabolic syndrome with lower microbial diversity were more likely to benefit from lean donor FMT than those with higher diversity as baseline. And this is quite straightforward because if you have to paint a wall, it's better to paint a blank wall and not a colored wall, basically. Harris O'Connell and colleagues in this beautiful review article show that also some genetics and immunity-related recipient factors can influence the donor microbial engraftment by influencing the maintenance of commensal microbiome or expanding some pathogens. Also, we know that the composition of the gut microbiome can affect the donor microbial engraftment. We had an indirect evidence by a Norwegian paper that showed that FMT from a super donor, so a donor with the clinical characteristics of a healthy microbiome, for example, breastfed or born by vaginal delivery, healthy with a healthy diet, rich of fibers, was able to achieve surprising levels of efficacy in IBS, nearly to 90%, while no drug in the IBS has ever addressed such response. More precisely, the group from Rupert Leong and colleagues showed that the recipient of some donors were more likely to achieve clinical remission than others, and the key of this discrepancy appears to be the alpha diversity and mainly evenness, even because people who received batches from the wrong donor, but so the donor with the lower evenness, but receiving batches with a higher evenness than the other, basically they responded as well as the people who responded, who took the feces from the right donor. Another point is the protocol that we use in FMT. We can have some FMT adjuvant. We have shown that the antibiotic conditioning can improve the strain engraftment. And Karen Madsen will show later that low fermentable fibers can prime the microbiome engraftment and the clinical response. Anyway, apart all this ecological and microbiological stuff, I believe that some cultural, some mindset shifts are needed to raise the bar of FMT in chronic disorder. The one is the issue is the duration of therapy. Another one is the use of microbial monitoring for our patients. First, we know that the chronic disorders are basically should be treated by chronic therapies. Would you ever treat diabetes with just one course of insulin or hypertension with just one course of furosemide? No, never. So why should we do the same in FMT? And this is not just my viewpoint, but it's also supported by several evidence that the engraftment is basically low if the FMT is done one shot, and the efficacy and the clinical response are basically loosened over time as well as long as the engraftment is going to be lost. Another point is the issue of addressing microbial determinants to get success. We have shown that the composition of the donor microbiome may affect the clinical outcomes. So basically, I don't know where, but in a time, monitoring of donor microbiome will enter the clinical practice in the future, and we need advancement because there is also several approaches that we can use to monitor the donor microbiome, from the 16S to the latest advancement, for example, shotgun metagenomics with metagenomic assembly approaches. As we can show here, with a metagenomic assembly-based approach, we can track your strain, so you can track if the donor strain has replaced the recipient strain. And basically, this is really important. Think about FMT used for the cure of antibiotic-resistant bacteria. We have also another approach that is very fancy at the moment, which is the machine learning. In these tandem papers that we published in Nature Medicine, we have shown different approaches, but I still don't know if this is the future. But the only thing that I know is that this should be somehow clinically driven, so it should have a clinical sense. Even the machine learning should be done with a clinical sense. I'm very happy to say that this paper that Rupert Leung will show shortly later is a very innovative trial, is probably something that is bringing forward the FMT in clinical practice. They used an antibiotic preconditioning, a long-term therapy, a whole genome sequencing, and with a metagenomic assembly approaches. So everything what I said before. So congratulations, because I think that the new trials should learn from this trial. Well, can this knowledge be translated into the clinical practice? There are two issues, the testing issues and the reproducibility issues. First, there are current microbiome testing that a lot of our patients bring to us to be interpreted have several flaws. First, there is no definition or standardization of consensus in how to ship, how to store, which are the sequencing methods, and how it should be reported. I remember that, at least in Italy, but I learned all over the world, several microbiome testing provide also some clinical advices, and with some probiotics that should be taken, or some prebiotics or diet. And in clinics, we don't do this. Would you ever, if you were a radiologist, would you ever prescribe what to do to your patient after a CT scan? No. So why should we do with microbiome testing? To cover this gap, we have organized an international consensus conference to establish the criteria for reporting the microbiome sequencing in clinical practice, and basically to regulate the provision and exploitation of this testing and to promote the knowledge and the culture of the human microbiome field. There are several clinical and non-clinical microbiome experts, and we are on a very advanced stage. Another issue is the reproducibility. If you even find the best donor in the world, at the first pneumonia that he has, you will lose his microbiota, basically. So specific donor microbial signatures are highly reproducible, especially FMT should be repeated over time and used in the long term. So basically a new future, a new era of microbial modulation is advocated to come. So from the less precise FMT to probiotic, prebiotic, and diets, or antibiotics, bacterial consortia, to more precise items, for example, bacteriophages or metabolites. In conclusion, and thanks Harry Sokol and Nicolas Benek for this review that we did with the Sokol Lab and the Segata team, the landscape of factors influencing the FMT efficacy is multifaceted, from donor-related factors to recipient-related factors to protocol-related factors, and each other are connected. I leave you with the final message. Today there is a gap between the microbiome basic scientist and the clinician involved in dysbiosis-related disorders. Apart people that are in this room, I think that few people in the clinic are able to understand what microbiota is, to understand what is Shannon diversity, breakout dissimilarity, and so on, or what fecal Libertarium prosnitzi or Akkermansia or other bugs are able to do. I think that as it happened for other fields of medicine, I think that we should cover this gap, and events like this are very appreciated because they help to fill in this gap, so to build the so-called figure of the microbiome clinician. And I invite you to use this hashtag around Twitter to promote this kind of movement. I invite you to the Helicobacter and Microbiota Study Group workshop that will be in Antwerp next September. Special thanks to the collaborators, Nicola Segata and team, Sokol and team, Malish and team, Tilga and team, the all expert panel of the Consensus Conference of Microbiome Testing, and many others, and obviously all the team in the Catholic University of Rome and the Gemelli Hospital from the Digestive Disease Center and Microbiology Unit, and a very special thanks to the engraftment crew that are here. Thanks.
Thank you. That was very good. We have time for some questions, actually, from the audience. Okay, we have second row and third row.
May I start? Thanks for the presentation. I'm right here. Okay, thanks you very much. I like the metaphor of wall painting. Sometimes we need to do several layers before it takes the color. And also, well, I just want to mention that FMT is still highly empirical, as you suggest, and science seems to tell today that if we mix a complex ecological drug into a recipient ecosystem, then both may matter, the recipient and the donor, as you mentioned. For the 10 papers that we have on FMT in ulcerative colitis, it seems that pooled donations allow more consistent positive results. This would improve reproducibility somehow. So what is your views on the potential benefits of pooling ecosystems for drug development and in terms of clinical efficacy?
Oh, well, thank you for the question. On an ecological point of view, that's great because you increase the richness, the diversity, and the evenness of the, whatever you want to call it, of the donor. But we have to remember that there is a huge safety issue for FMT, and there's a huge pressure from the regulatory systems all over the world against the FMT as a potential transmitter of disorders or of harmful microbial profilings. So I think that would be complex if we consider transplant as a tissue. It would be complex to track, in case of adverse events, what happened and because of what, because of which donor.
Okay, second row there.
Very nice presentation. So as we're looking at the development of FMT preparations, there's lots of disadvantages in that there's a variety of issues of safety. What do you think of these newer living biologic agents that are more purified and come from, they basically are defining the strains that are putting it, they find a healthy donor and then they purify some healthy strains. They seem, there's I think 4 of them under development, they seem to show some effect, but some of them don't. Do you think the future of FFT is it better to give the mix, or are we more confident in what we're giving when we give a purified preparation?
Yeah, thank you for this relevant question. Basically, I think that the microbial consortia will probably be the future, especially for chronic disorder, because for chronic disorder we need some fine-tuning, while for C. diff we need just a healthy biomass. But at the moment we have human data only for C. diff for this consortia. So I'm waiting for the new results in other disorders. For C. diff, I think that the two pathways can easily go parallel. So the centers that are able to do FMT continue FMT, and centers that are not able to do FMT can basically buy it.
Other questions? Oh, back here.
Gianluca, thank you very much for this very nice presentation. FMT and IBS. At the beginning, we saw the first trials were going all over the place. Some trials were positive, some trials, even the placebo was better than the FMT itself. So we reasoned that probably IBS is a very complex condition, is heterogeneous, and maybe some patients have downgrowth, others have overgrowth, and the microbial community there is all over the place. But then it came that trial from Norway that showed that huge gain over placebo. And so in that trial that we commented together in a paper, we reasoned that probably the super donor that they found in that particular study was the key to get those results. So do you think that the super donor is important in these type of disorders?
Yes, definitely the super donor is a kind of evidence that a specific microbiome can work better than other. But my concern of the super donor is that it is just something limited to the research, because it's not possible to expand it in clinical practice, because it's very hard to find a super donor, and it's even harder to keep it. Another point with IBS, I think that IBS is a very multifaceted disease with several pathways that contribute to the development of the disease. So I think that probably we should focus on a specific subgroup of IBS, probably post-infectious, I don't know, but I think that we should define the cluster of patients that could benefit.
Third one, Emma?
Propose FMT as a therapy, shouldn't we make sure that it actually plays a causative role in, like, for example, all these chronic brain disorders?
Sorry? Can you repeat?
No, what I don't know if this is turned on. What I'm wondering is, shouldn't we first do what has been done in the mouse models, that we clearly can establish causality of an abnormal microbiome in several disorders, definitely in all the brain disorders, before we talk about FMT as a therapy and setting up clinics? I'd just like to hear your, I mean, there's a lot of discussion about, you know, it's so hard to translate the animal studies into human findings to prove the relevance of the microbiome in disease processes. But listening to your talk, you almost assume that has already been accomplished, and we should focus on the disease optimization with FMT.
Well, the causation association issue is very relevant in microbiome studies. For example, if I take 20 patients with ulcerative colitis and I study the microbiome, this is an associative study, not a causation study. To see if the microbiome causes ulcerative colitis, I have to do a transplant model in a mouse. But with FMT, as every therapeutic intervention, as every therapeutic trial, and most of them now are against placebo, so are randomized controlled, basically they are causative studies. One difference between the mouse model and the humans is that the mouse models have much less variables that can influence. For example, in the study from the Newdorf Club, in metabolic syndrome, basically patients regained weight, or insulin resistance because of the loss of the engraftment over time, but also because they kept again their diet. So this is a variable that you in mice can control.
Okay, thank you very much.
Thank you.
So I'd like to introduce our next speaker, Dr. Rupert Leong. He's head of inflammatory bowel disease services at Concord Hospital and a professor of medicine at the University of Sydney. His previous research has received awards, namely work he's done on epidemiology of IBD in an Asian population. And he's been a real leader of FMT in Australia, previously chairing a working group on regulation of FMT, a very important topic. He's going to talk to us today about FMT and ulcerative colitis.
Thank you. Thanks very much, Colleen, for your very kind introduction. And good morning, everybody. And it's a real pleasure to join this conference. It's been fantastic. I've learned so much. So I've been asked to talk about FMT in ulcerative colitis. As you heard from Gianluca, this is the first chronic disease to really be studied with microbial manipulation. So you'll all be familiar with the concept of eubiosis that occurs in a healthy body state, but inflammatory bowel diseases is characterized by dysbiosis. So there's increase of pathogenic organisms and decrease in the protective anti-inflammatory organisms. And so it makes a lot of sense to try to manipulate this with fecal microbiota transplantation. So this is a powerful form of microbial manipulation, and it can essentially be a potential therapeutic opportunity. So we asked gastroenterologists around Australia what I thought about it. So the perception of FMT in gastrointestinal disease was that there was a lack of evidence. So to answer this, Sudarshan Paramsathi, Michael Kam, and Nadeem Kakush got together and decided to ask the question whether microbial manipulation may be able to treat ulcerative colitis. And they did this through a randomized placebo-controlled trial, recruiting patients with active ulcerative colitis, treating them with initially a colonoscopic infusion of FMT, followed by 5 times per week enemas for 8 weeks in order to look for the ability to induce remission in ulcerative colitis. And they chose mixed donors, so 3 to 7 unrelated donors were used per patient, and this increased the opportunity of finding the right organisms that might be useful. And as Ju and Luca mentioned, we don't do that nowadays because of the inability to track patients after the infusions. So donors underwent very extensive screening. Only 1 in 10 made it to the final donation phase. So this is a study design where patients with mild to moderate ulcerative colitis, as defined by a Mayo score of between 4 and 10, were randomized to receive an initial colonoscopic infusion followed by 8 weeks of 5 enemas that were self-administered of either FMT or the identical placebo. And the primary endpoint was at week 8, which was defined as clinical remission plus endoscopic remission or response, so very hard endpoints. For patients that were randomized to receive placebo, they were given an opportunity to receive 8 weeks of open label therapy thereafter, and they were then assessed at that time for follow-up as well. So here are the results of the FOCUS study with the week 8 induction results, with the left graph showing the primary endpoints of clinical remission with endoscopic response and remission. demonstrating that 27% of patients randomized to the FMT arm achieved this outcome compared to only 8% in the placebo group with the risk ratio of 3.6. In addition, patients randomized to receive FMT had higher clinical remission, clinical response, and endoscopic improvement over that of the placebo group. So you can see one of the two patients was mine, and she had a Mayo score of 2, demonstrating very nice results after the FMT treatment at week 8 with mucosal healing. So this and the subsequent Sam Casella study, plus the 2 original study published in Gastroenterology, 3 out of the 4 were positive. So Colleen was involved in our consensus statements, suggesting that we should place induction of remission in ulcerative colitis as a potential therapeutic target that can be successful with FMT. So we also recognized there were a lot of other questions that needed to be answered before we fully adopt this into clinical practice. One of which was the microbial diversity. So what Sudarshan found in the study was that there was a decrease in the alpha diversity of patients with ulcerative colitis, with the operational taxonomic units below that of a control population. So what he found was that following FMT, as well as 2 months after the FMT were completed, that patients were able to increase the diversity to the level of that of the placebo. Of the control. So you can see here that this is the control, so the levels of the alpha diversity was very similar after FMT. So that demonstrates there was some ability of FMT to actually shift the microbial environments. So you can also determine whether patients has a high chance of remission or not, even at baseline. So patients that had a good chance of entering into remission already had a high level of OTU compared to patients that ultimately did not achieve remission. So you can almost predict for who was going to respond to the FMT therapy. So following FMT treatments, those that were able to increase their OTUs above the levels of individual donors were the ones most likely to achieve remission beyond that of the ones that did not achieve this level. And you can also see the shift in the fecal microbial composition of the baseline, as well as the ones that receive placebo, towards that of the donor batches, indicating that there are true microbial shifts that occurs with FMT. And we already know that metabolites are very important, and short-chain fatty acids are associated with improving the tight junction function of the intestinal mucosal barrier, as well as tryptophan metabolites, but also secondary bile acids having the ability to regulate cytokine production. So we're very interested in what happens to the metabolites. And indeed, Sudarshan's work showed us that for those patients with ulcerative colitis that entered into remission, there was finding of metabolic pathways of increased short-chain fatty acids along with secondary bile acid biosynthesis. And what was associated with the lack of remission was an organism called Fusobacterium. So on this analysis, patients that did not respond to FMT therapy tended to have Fusobacterium, which was one of the factors that demonstrated the lack of success. And also another organism, which is a beta proteobacteria called Saccharella. In fact, Fusobacterium was a very powerful negative predictor of response. And you can see that for patients in the blue bars indicating the lack of remission, they have a higher average relative abundance of Fusobacteria versus the ones that did enter into remission in the red bars. And this was true for the blinded aspect of the study, but also to validate it in the open label aspect of the study. This previous publication was in 2005, and it showed that use of antibiotics, amoxicillin, tetracycline, and metronidazole was able to successfully decrease the Fusobacterium verum compared to baseline in the patients with ulcerative colitis treated with the antibiotics versus the ones that were not treated with the antibiotics. But not only did it decrease the Fusobacterium, but also led to symptomatic improvements as well as endoscopic improvement at 3 months and at 12 months compared to those that did not receive antibiotics. And around that time, we also were aware of the Staley data that demonstrated that oral FMT capsules were possible in the treatment of C. diff infection. So pre-FMT, there is a loss of the diversity and relative abundance of various organisms that was able to be recaptured with FMT therapy, but also sustained for at least 2 months after therapy. And we then followed focused studies and realized that when patients stopped therapy, they had a high chance of flaring. So the median time to flare was about 6 months, where at 6 months, half of all patients that had benefited with FMT on the focus study had clinical relapse. So this led us to design the LOTUS study, and we want to answer 4 questions: whether oral encapsulated lyophilized FMT was possible in treatment of ulcerative colitis, whether selecting high-quality donors can increase the efficacy rates, and use of antibiotics preconditioning, especially targeting Fusobacterium, can improve the outcomes. And we also want to speculate whether maintenance therapy would help to increase the durability of response. So we recruited a patient cohort that was exactly the same as the focus study, multi-moderate ulcerative colitis, with the characteristics as demonstrated there. So this is a study design where patients with active ulcerative colitis, a Mayo score of 4 to 10, were all given antibiotics for 2 weeks, comprising of amoxicillin, tetracycline, and metronidazole. Then patients were randomized 1-to-1 to receive only oral FMT for a duration of 8 weeks, with very high dosing for the first week of 24 capsules per day. For the second week, it was 12 capsules per day, and for the 3rd to the 8th week was 6 capsules per day. And the primary endpoint, exactly the same as the focus study, was combination of clinical remission plus endoscopic remission or response. Patients that responded to therapy were then re-randomized to either continue FMT therapy for another 48 weeks or to withdraw FMT therapy. So they would then reassess at week 56. This part of the study was not placebo-controlled, so we used a blinded endoscopist and a histopathologist in order to determine whether there was a good efficacy outcome. So you can see here the maintenance phase, patients only needed 2 capsules of FMT per day, and the adherence to this was very high. So March 2020, we had recruited 35 patients in the study, and then we were limited by the COVID-19 pandemic. At that stage, we had enough capsules to continue the study for all 15 patients that were randomized to FMT to ensure that they go through to the final maintenance period. So we made the decision that we did not need any new FMT donations if we stopped recruitment at that time. So indeed, that's the decision that we made. So you can see the comparison of the 2 arms, the FMT arm versus the placebo arm. It's a much smaller study than we initially designed, but overall there's quite good balance. 2 of the patients randomized to receive FMT had failed biological agents before. One was to infliximab, the other was to vedolizumab, and none of the placebo group patients had failed biological agents previously. So here are the results of the LOTUS study. The left bar graph indicates the primary endpoint was achieved in 53% of patients randomized to receive FMT versus only 15% in the placebo group, with an odds ratio of about 5. And you can see that the proportion of patients entering into clinical remission, endoscopic remission, favored that of FMT over that of placebo. We did see a very high placebo response rate and an endoscopic response rate in the placebo group, but they weren't true placebos because they all had received antibiotics beforehand. So whether antibiotics improved the outcomes of the patients in terms of response, but not to the degree of hitting remission, was probably what happened in this case. So we were also really interested in the 11 patients that entered into the response arm. So 4 of them were randomized to receive open-label FMT, and 6 of them withdrew FMT. Of the ones that withdrew FMT, they actually flared, and using the cutoff criteria, they all demonstrated active inflammation according to fecal calprotectin or on endoscopic evaluation. So here are the results. 4 patients that continue on FMT therapy, they all did very well in maintaining the clinical remission rates. And 6 out of 6 patients that withdrew therapy flared. So this is obviously a very small subset analysis, so we can't make too much of it, but the endoscopic and histological assessments were performed by a central blind reader who were unaware of the allocation of the patient's results. And you can see that these are the 4 patients that made it to week 56, demonstrating that they all did relatively well by week 8 during the induction phase of the study, but by week 56, they essentially had normal-looking mucosa with a Mayo endoscopic subscore of 0, but also the histology demonstrated a Nancy score of 0, indicating histological remission as well. So we also looked at the fecal calprotectant, demonstrating that in the green was the FMT arm and the red was the placebo arm. They had similar levels of fecal calprotectant between 6 to 750 at baseline. The ones that randomized FMT decreased, but the ones that received placebo also decreased, possibly because of the baseline antibiotics that they had. But if patients continue on FMT, the fecal calprotectant will suppress even further, whereas patients withdrew the FMT, the calprotectin increased. So there was almost a statistically significant difference, even though we have very small numbers at this part of the study demonstrating that there was a divergence of results. So I'm putting here the results of the LOTUS study next to the FOCUS study because they actually directly comparable in terms of the definitions we use for endpoints and also the severity of the patient. So you can see that the outcomes of LOTUS studies in terms of magnitude and also the deltas was higher than that of a FOCUS study. So that suggests to us that perhaps oral FMT does well, but also antibiotic priming may be very effective as well. In terms of serious adverse events, there were a few cases of patients having worsening of their ulcerative colitis, of once randomized placebo as well as FMT. One patient required colectomy in the FOCUS study. But a lot of the symptoms were quite minor, consistent with anyone who has had FMT. In the LOTUS study, none of the patients required colectomy. This is the Crothers paper that had 15 patients randomized, and there were results for 6 FMT and 6 placebo. And you can see that the modified Mayo score decreased around 4 to 12 weeks in patients that were doing well on FMT. And compared to the FMT non-responders, the FMT non-responders tend to be a lot sicker. They had a baseline fecal calprotectin over 1,000. So there was no improvement in that group. This is a study from India, from Ajit Sood, and he found that this is a real-world cohort of ulcerative colitis patients who were steroid-dependent when they were entered into the study with a mean Mayo score between 8 and 9. So about a third of them had been exposed to anti-TNF therapies as well. What he did in this open-label study was that patients received 7 infusions of colonoscopic fresh FMT, fresh or frozen FMT, at weeks 0, 2, 6, 10, 14, 18, and 22. And the endpoint at week 24 demonstrated that 46% of patients had entered into steroid-free clinical remission. In addition, 63% were in endoscopic remission, and he found that there were no serious adverse events. He then took this cohort of patients, enriched it further, so there were 112 patients that received this regimen of 7 open-labeled infusions of FMT. 65 out of those 112 had responded, so remission rates was 53%, and 61 of them agreed to have a further study, which was a randomized withdrawal study. So half of the patients had ongoing FMT infusions given colonoscopically, and the other half had placebo given colonoscopically. So I'd love to be working in India where you can have 14 colonoscopic infusions, and patients were happy with that. So this demonstrated that FMT continuation had a higher rate of clinical remission, but this did not reach statistical significance. But what did reach statistical significance was endoscopic remission and histological remission. So this tells us that there is some ongoing benefits of patients with FMT compared to those that withdrew on therapy. All right, so are there ways that we can improve FMT outcomes in ulcerative colitis? Well, here are 6 potential strategies. Firstly, find a super donor. Secondly is multiple administrations of FMT. Third is preconditioning of antibiotics. 4 is to give a diet to the donors of the FMT. And number 5 is to combine diet therapy with the FMT. And number 6 is potential for the defined consortia. So super donor effects is recognized, and you've already heard about that from Gianluca. So we found that one patient had 100% efficacy versus 36% efficacy in a second donor. And what was the key difference between these two subjects were that of species evenness. So species evenness is a way of defining that this is a robust ecological niche that the organisms were in, and there was very little fluctuation or variability. And perhaps this is a very important factor to be a super donor. So in the publication, it shows that if there is a dispersal on this PCA, then the donation doesn't tend to be as effective as a very concentrated PCA analysis. So next is single versus repeated. The left meta-analysis is for single FMT, looking at the remission rates, and this was about 19% for ulcerative colitis. And for repeated FMT, either orally or fecally delivered, was about 43%. And for Lotus, if we were to include this study, it will hit the clinical remission rate of about 73%. This is using antibiotics preconditioning before the FMT. No antibiotics achieve a remission rate of about 29% on this meta-analysis, and up to 51% for subjects that received antibiotics prior to the FMT. And once again, Lotus would push that out further to the right. So what happens with antibiotics? Well, antibiotics decreases the species richness, it decreases the species evenness, and it also decreases the Shannon's diversity. So it doesn't look great, but what it has done is to decrease the fusobacteria as well as Saturella, which we found were the negative predictors of efficacy in the previous focus study. We also found that the recovery of the species was good to differentiate the non-responders from the responders. Non-responders had very rapid escalation of the species richness, and the responders had a very gradual increase. So I'm not sure what that means, but it shows that there is a difference in the re-engraftment speed as being potentially important. Also, in metagenomics, there were strains that were differentiated between donor 1 and donor 2, the super donor versus the not so good donor. Now, what about diet? Well, there have been subsequent studies with our increasing interest in diet, and you'll see from the rest of this meeting that there's been a lot of diet focus. This is a group of patients with mild to moderate ulcerative colitis in New Delhi with Vineet Ahuja, with a baseline fecal calprotectin of up to about 430, so not very active disease. And they were treated with 7 weekly colonoscopic infusions of FMT, fresh multi-donor. And they were followed up with an anti-inflammatory diet. What is an anti-inflammatory diet? Well, it's high in soluble fiber, it increases the short-chain fatty acids, and has fermented foods. And it also avoids the inclusion of dairy, gluten, red meats, and processed foods. So the question is whether ongoing use of an anti-inflammatory diet can help enhance the effects of FMT without needing to carry on with the FMT. This was compared against standard medical treatments, which was open-labeled and physician discretion, and a lot of this was just topical steroid increase, which I don't think we really do as clinicians. We tend to either, if someone's not responding to topical steroids, instead of increasing the dose, change to oral steroids or add 5-ASA therapies. So here are the results, with the left panel being the 8-week induction results, and then 48 is the maintenance results. There is a difference with FMT and diet having a high proportion of patients achieving clinical response, but as well as deep remission at 8 weeks and also at 48 weeks. This was numerical at week 48, but statistical at 48 weeks for deep remission. So it does look like that diet can carry on the effects of FMT further. This is another study that randomized patients into 3 arms, and the first arm was a FMT therapy given as infusion on colonoscopy followed by 2 enemas, as well as a liberal diet. And the second arm is to use FMT that has been preconditioned through 2-week diet for the donors. And then patients receiving the FMT in the same way as group 1 were also given a diet called the ulcerative colitis elimination diet. And the third arm was the ulcerative colitis elimination diet alone. So this is what the ulcerative colitis elimination diet looks like. It has high fruit and vegetables, pectins, low saturated fat, low dairy fat, and exposure to tryptophan and low oligofructose, amongst other things. This is what happens with the preconditioning, feeding your FMT donors. Essentially, there was no difference in the Shannon diversity as well as the microbial analysis of the donors before and after the diets out of these 7 donors. So the results were terminated early because of futility. So they recruited 53% of the planned cohorts at that stage, and the results showed there was no statistical significant difference between the 3 arms. However, the patients that did receive just the ulcerative colitis elimination diet numerically had the greater response at week 8. And that was a little bit surprising, and I guess a little bit disappointed for me as well. And I wanted to see FMT and the diet having a better outcome, but that was not seen in this study. So to date, 10 randomized controlled studies for ulcerative colitis. You can see that this is a very heavily studied area, mostly for induction, but also now a few in the maintenance space, but also with diet. What are the predictors of response? Well, for FMT donors, there are the high diversity, there are the taxonomic differences, and the ones that predict for non-response as well. And perhaps donor evenness can be a factor that can be included into that as well. For patients with ulcerative colitis, perhaps the milder disease, younger the disease, can have a better outcome. In terms of FMT, antibiotic preconditioning, multiple administration, it can be fresh or frozen, and it can be any route of administration as well. For those that respond, tend to have better of the good organisms, and maybe slow engraftment can be a feature as well. I'm not sure about that. But the non-responders tend to have no change in the diversity and the presence of the adverse organisms such as proteobacteria and fusobacteria. So you can see that this is a very complex algorithm. So can precision medicine, individualization, and a treat-to-microbiome approach be used to improve outcomes in ulcerative colitis? Well, this is what Gianluca actually did. He found that was a way of modeling and to predict for which organisms would best match a particular subject. So this modeling was able to increase the richness after FMT beyond that of just the donor's richness by itself. So defined consortia was asked previously as well. So only one of the 3 companies that, as far as I know, looking at ulcerative colitis is still remains in the game. And the 2 graphs at the bottom demonstrate that the series products in ulcerative colitis essentially failed. So they did not show any efficacy in the 287 and the 301 studies. So in conclusion, FMT leads to rapid microbial changes and can be sustained for months. Fresh frozen routes have similar results. Engraftment and increase of metabolites are efficacy biomarkers. Multi-FMT and/or anti-inflammatory diet may help to sustain the benefits. In terms of recipient, higher alpha diversity, lower inflammation may respond better. For donors, evenness, taxonomic and metagenomic signatures may improve efficacy. Antibiotic priming, I think, probably improves efficacy. Pre-donor conditioning of diet, I think more data are required. And prediction and personalization may help to match the donor's stool constituents versus the recipient's requirements. So further data are obviously required for a lot of other issues as well. So I'd like to acknowledge my collaborators, so Craig Hafer, my PhD students, so Sudarshan and Nadeem continues to be outstanding colleagues to work with. Thank you for your attention.
Thank you, Rupert. That was an excellent talk. We have a few minutes for questions. In the back there, hand up.
Gianluca Iannino from Rome. Rupert, thank you for this excellent presentation. I have a question on your opinion. In your opinion, what will be the position, the clinical positioning of FMT in ulcerative colitis? So in patients with refractory to biologic therapy, so very late, in a very late stage of the disease, or very early? And which is the comparator? Is biologic therapy or mesalazine? Because usually the people enrolled in FMT trials are not severe. So they are not the same population of the biologics. Probably the comparator could be salicylate. What is your opinion?
Thank you. That's a fantastic question regarding positioning of FMT in ulcerative colitis. I think at the moment it is going to be early in the disease and in the lower severity cohort, because I think that's the greatest gain you're going to get from this product and the least risk of harm. Because once patients have a lot of broken down barrier function, they are at risk of getting FMT worsening the disease. So I wouldn't like to harm patients. I think the cohort that will like to be on this therapy are, we all have these patients, the ones that don't want to go into drugs. So you give them a non-drug option, and I think they will go for it. Question regarding combination with other drugs, I think we need to do those studies. I think it's a great opportunity. Not a lot of studies have included biological agents with FMT, but I think we had 2 patients that have failed biological agents that still benefited from FMT at the end of the day. I think it's the level of the 5 ASA treatments and a combination of 5 ASA should be safe, and maybe you get incremental gain because the therapeutic pathway is completely different.
Thanks. Harry, did you have a question? Right here, 3rd row.
Thank you very much. It was a very great talk. I'm like you, I was a little bit disappointing by the Israeli study, and honestly, I don't know how to interpret these results. Do you have any hypothesis of why this study failed?
I'm not sure at all. I know they finished the study recruitments when they still had another 50% of patients, so I'm not sure.
Thank you for a very nice talk. My question is about sustainability. That group that you took off of FMT, it looks like you really need to continue the FMTs. Or do you think this was just serendipitously a subgroup that had more aggressive ulcerative colitis that sort of created the continued ecosystem that would make engraftment not sustainable?
Yeah, that's a great question. I think being a chronic disease, FMT as a single course is not going to be curable. So that's what we tested, and it's not very useful. But what we did find on the LOTUS study is that you can give very small amounts of FMT to sustain the benefit. So just 2 capsules a day was enough to keep these patients going, so they actually maintain the benefit over time. So once there is good healing of the intestinal barrier, perhaps you've already got a nice eubiosis going, maintaining eubiosis may be a lot more straightforward. I think there will be differences with different populations and severities. Some bacteria is more important, others will be more other pathogenic pathways of inflammation, immune system escapes. So I think bacterial therapy is only for perhaps a subset of patients, and they're the ones that most likely benefit from it.
Okay, one more question.
Yes, here, Pierre de Charlotte. I would like to come back to the positioning of FMT versus conventional 5-ASA therapy, also in medium severity disease. We have efficacy data, but do we have any efficiency data so far? I mean, what is affordable for the socioeconomic system in comparison with the very high resources which are needed for FMT treatment in moderately severe patients versus commonly available drugs? How would you see the methodology to address the medico-economic aspects of the question?
Oh, that's a very difficult question to answer. I think there's such large variability in the cost of FMT at the moment, from the different routes of administration to the preparation, the licensing involves, the patents, etc. I think that would make FMT quite an expensive treatment. So yeah, I think that needs to be included in any advice to use this therapy.
I think that was great. Thank you very much. We'll cut off there. It'll be time for more questions at lunch. We'll have a... So our final speaker of this session is Dr. Karen Madsen. She's a professor of medicine at the University of Alberta. Her research involves mechanisms of environmental and diet influence on host microbial interactions, and she's interested in the design of effective therapies to manipulate the gut microbiome for disease. She's going to talk to us today about FMT with fiber supplementation in metabolic syndrome and obesity.
Go back. Excellent. Thank you very much for the kind introduction, and thank you to the organizing committee for inviting me. So I'm going to shift gears a little bit and talk about FMT and metabolic syndrome. So metabolic syndrome is highly prevalent around the world. It's estimated that 1 in 5 individuals have metabolic syndrome, and over 40% of individuals over the age of 65 have metabolic syndrome. So it really is a constellation of symptoms, including low HDL cholesterol, high triglycerides, hypertension, high blood glucose, and it's usually associated with visceral obesity, although not always. But obesity and metabolic syndrome are risk factors for the development of diabetes, liver disease, stroke, and cancer. So it's obvious that causes of obesity and metabolic syndrome are multifactorial. So we all do Zoom meetings now, advances in technology. So we don't walk down the corridor to see our colleagues. We sit at home, turn on our computer, so we're not walking anywhere anymore. Lack of physical activity. Medications we're taking a lot of medications that affect our metabolism. Obviously, stress and lifestyle factors have key roles, genetics and epigenetics as well. But looking at the microbiome and our diet and how these are interacting to cause metabolic syndrome. So looking at large population type studies, and looking at microbiome association and connections with host metabolic factors have shown that there are clear associations. So in this PREDICT-1 study, they looked at over 1,000 individuals looking at personalized responses to dietary composition. And what they did was they took 1,000 individuals in the UK and discovery cohort, and then they looked at the validation cohort, 100 individuals in the United States. They did deep metagenomic sequencing of the stool samples. They did a whole host of looking at what the people were eating, food frequency questionnaires. They did postprandial studies of responses to mixed meals. They did fasting blood glucose parameters, and of course they did the personal age, gender, etc. And they found clear associations between different microbial profiles and different diets. And overall, they found that the microbiome composition was predictive for a large panel of cardiometabolic blood markers, including fasting, postprandial, glycemic, lipidemic, and inflammatory indices. So clear associations in large population studies. This next study took individuals, healthy controls, and then they took individuals with metabolic syndrome, type 2 diabetes, either treated or untreated, and then they took individuals with ischemic heart disease, acute heart failure, and they looked at these individuals thinking that it was like a longitudinal study because patients with metabolic syndrome are kind of on their way towards maybe heart disease and heart failure. So they looked at over 1,200 middle-aged Europeans, along with some healthy controls. And they looked at this group in the middle, the people with a dysmetabolism, either treated or non-treated. And what they found that was common in this group was this reduction in gut bacterial cell density, a loss of short-chain fatty acids, increased production of branched-chain amino acids. Metabolites were increased like TMAO, trimethylamino oxide, and compounds derived from tryptophan and phenylalanine molecules. So again, a clear association with changes in the microbiome with dysmetabolism. And we know from animal work, dating back to the initial studies by Jeffrey Gordon, that there are significant differences in host metabolism in germ-free versus control mice. Germ-free mice are resistant to diet-induced obesity. You can do fecal transplants from humans. We've heard a lot about that. And you can transfer phenotypes of obesity and metabolic syndrome into mice. And if you do selected association type studies, some microbial species will induce host metabolism dysfunction, and others can protect. So a lot extensive experimental evidence in animal models. And from these animal models, these are kind of the general mechanisms that are proposed to underlie the effects on host metabolism. Short-chain fatty acids, we've heard a lot about them. They do affect host metabolism. They do go through GPR-coupled receptors. They do increase GLP-1. They do increase PYY. They will alter liver function. They will alter satiety in the brain. And they will affect intestinal transport. LPS, a lot of patients with obesity have a chronic low inflammation with increased levels of LPS signifying a breakdown in gut barrier function. This can induce inflammation throughout the body, which can reduce insulin sensitivity. Obviously, metabolism of the bacteria and metabolites, such as TAMO, branched-chain amino acids, can have an effect systemically. And bile acid metabolism, different bile acids have been shown to have huge effects on host metabolic factors. So a lot of this from animal models, some from human studies. And if we look at several associations between, again, obesity and gut microbes have been shown. So these are kind of the general ones that have been shown, with leanness associated with some of the firmicutes, some of the Bacteroidetes, some proteobacteria, Akkermansia, and some actinobacteria. Whereas associated with obesity have been some of the firmicutes, again, some of the Bacteroidetes, some proteobacteria, and Fusobacterium. So again, a whole host of association studies. And some of the most common findings in these association studies, again, is this low diversity, low gene richness, leading to changes in host metabolism. Okay, so now if we look at therapies to improve the host metabolism through modulating the gut microbiome. This was the very first report back in 2012 now, where they took the FMT from lean donors. They did a one-time duodenal infusion, and they showed improvement in insulin sensitivity at 6 weeks. They did not show any effect on weight. They didn't show any effect on GLP-1, GIP, or PYY. However, the effects were transient, and they had specific changes again in metabolites in the plasma. They did see increased Akkermansia, was one of the main findings, and the metabolic response was linked with lower initial fecal microbiota diversity. This next study, which was published in Science, they took patients with type 2 diabetes, and they did a randomized controlled trial. And what they did is they put patients either on a high fiber diet or standard of care for 3 months. And then what they found was that the patients on the high fiber diet had improved glycemic control, and they took time samples. So they found that the changes in the gut microbes preceded the improvement in glycemic control. And they went on to show that they could take that phenotype, transfer it to germ-free mice. So they took the pre and post stool samples from the patients, transferred it into germ-free mice, and it showed the same phenotype. And what they showed was the improvement was associated with, again, a select group of acetate and butyrate producing bacteria. So fiber. if you look at the relationship of fiber to metabolic syndrome, dietary fiber intake inversely associates with the risk of metabolic syndrome. Looking at the RESOLVE study, what they did in this study was they did a 3-week initial intensive diet exercise intervention in 100 patients. And then they put them out and they gave them 12 months of free living. So they actually kept people in a room for 3 weeks. And then they monitored their diet. The diet included low lipid and high protein, high fiber. And after 3 weeks on the diet, all the subjects had improvement in glycemic control. And then when they put them out into 12 months of free living, and then they looked at which patients maintained what they had induced in that 3 weeks, only the patients who maintained a high fiber intake maintained the beneficial effects that were induced in that initial 3 weeks. So fiber is important. I know we're going to hear a lot about it tomorrow, but it's non-digestible carbohydrates that are utilized by our microbes. And what you have to remember about fiber, which I'm sure we'll hear a lot about tomorrow, is that there's a wide spectrum of physiochemical characteristics between insoluble versus soluble, viscosity versus non-viscous, and fermentable versus non-fermentable or low fermentability. And fibers will fall anywhere along the spectrum. And depending on where they fall on that spectrum, they will have very different effects in the GI tract. And if we look at what happens when you ingest fiber, there are a multitude of effects in the upper small intestine from fiber. Fiber can interact with epithelial cells, can interact with immune cells and change gene expression in the upper small intestine. Viscous fibers can trap molecules. They can change the amount that's absorbed because they're binding it and taking it down. They can change the rate of transit. When they come into the colon, obviously you're always thinking about the fermentability, induction of short-chain fatty acids, can promote bacterial growth. It can lower pH from the short-chain fatty acids. And as it goes down, it can act actually for bacteria to actually bind on. It's a surface, and so you can increase bacterial cell numbers, increasing water retention, increasing osmotic effects. So they have a huge effect along the entire GI tract, not just in the colon. And we know that dietary fiber is metabolized by different gut bacteria to produce different kinds of metabolites. So the responses of the gut microbes to the fiber, this was a very nice study where they showed that there are some fibers that a lot of bacteria can act on. They're very simple, things like inulin and phos. So a lot of bacteria can ferment those and break them down and use them. But there are some fibers that only very few bacteria have the enzymes to deal with. So when you take a fiber, you have to have the specific bacteria in your gut with the enzymes to break it down in order to use it. So again, it's a very personalized, you have to match the fiber with your gut bacteria. So knowing this, and we were very interested because we've been doing FMTs, we thought that if you could do an FMT in obese metabolic syndrome and reset the microbes, could we then maintain effects by supplementing with fiber? Because we've heard a lot about it's an ecological system that we are transplanting. That ecological system is based on the donor's diet. That's what that system is used to having, is that donor's diet. You're putting it into a new person, they have a completely different diet. So why would you expect that FMT to be the same as the donor because it's a different diet. And asking somebody to change their diet is probably the most difficult thing you can do. People will not change their diet. So if we could use fiber then as a supplement to maintain the growth of the organisms that we think are the most important, could we then maintain it? Because giving repeated FMT is not as easy as giving a supplement of a fiber. And then how are we going to deliver it? Small intestinal, probably very important. A lot of people have used the nasal jejunal tubes, very invasive, not practical for use. So we elected to use the pills. And then we were deciding on what kind of fiber we wanted to use. And there's a lot of discussion when we were planning this trial as to what would be the best fibers to use. And then again, we thought single fiber or mixture. And the problem with using a single fiber is that you tend to feed one group of bacteria only, and they tend to overtake. Because we've done it in our mouse models where we fed one fiber, and one particular taxa would grow at the expense of all the other taxa. So we elected that we thought a mixture would probably be better. So this was our study design. We went for a 6-week period to match what had been shown before. Stratified by sex, inclusion criteria was metabolic syndrome age 18 to 64, and the average BMI was 45 in this group. So we used 20 oral capsules. We used 3 different lean donors with very healthy metabolic status. We did give them a bowel prep. We chose bowel prep over antibiotics simply because we thought bowel prep would be simpler. And we wanted something to clean out the system so we could replenish. For our fermentable fibers, we chose resistant wheat starch, acai gum, and soluble corn fiber because all of these feed a great number of different microbes, and these all have been shown to have a beneficial effect on metabolic syndrome. And then we chose cellulose as a low fermentable fiber as a comparison. And I wanted to point out that these patients, we took them from the Weight-Wise Bariatric Clinic. So all of these patients were receiving the gold standard for treatment for their condition. They were most all on drug therapy. They were all receiving counseling for nutrition, physical activity, and mental health, and they were all managed by the same clinical team. So this is the overview of the study. We had 68 patients. So they either received an FMT followed by fermentable fiber, just fermentable fiber with a placebo FMT, FMT with low fermentable fiber, and low fermentable fiber just by itself with a placebo FMT. Baseline FMT, 6 weeks on the fiber, and then they came back 6 weeks later so we could see if they had maintained any effects. No differences in clinical parameters at baseline. Average BMI was 44, so very severely obese, and as I said, most subjects were on medication, either metformin, GLP-1 agonists, or SGLT2 inhibitors. So what we found at 6 weeks was that the FMT and the cellulose group had improved glycemic markers, both an increase in insulin sensitivity and reduced fasting insulin. And we did not see any effects in the other 3 groups. We also showed that they had an improved enteroendocrine function, so we gave them an oral glucose test and looked at the increase in GLP-1 and the increase in insulin, and again, we saw an improvement in the low fermentable FMT group. We did not see any significant changes in either weight, blood pressure, although there was a trend towards decreased waist circumference, but nothing statistically significant. And when we looked at levels of short-chain fatty acid, they were not statistically different. There was a trend towards increase in the high fermentable group, which you would expect, but nothing significantly different. Although I would argue that short-chain fatty acids in stool are probably the least, they don't give you a lot of information as to what's happening inside the lumen. We did see several changes in microbial composition, especially, again, in the low fermentable group. We had increased Christianella, Bacteroides, and Akkermansia, decreased Dilaster and Rhumnococcus. We did see changes in the fermentable fiber groups, as you would expect, increase in Bifidobacterium and decrease in Rhumnococcus. Again, we saw the donor strains engrafted in the FMT and cellulose group, but not in the FMT and fermentable fiber group. We had 3 different donors. We did not see any differences between the 3 donors, and they were all evenly spread across the groups. And what we did see, that the baseline genus of Microbiota did predict the HOMA-IR result, in that Akkermansia and Prevotella showed the most predictive for a response to the FMT therapy. So just to go over this, FMT with a low fermentable fiber did improve metabolic parameters, and this was seen in patients who are already receiving the gold standard of therapy. And we were able to improve them further upon what they were already receiving. We did not see any weight loss over the 6 weeks. They did not change their dietary intake. We monitored that. None of them changed their drug therapy. We monitored that. No changes in short-chain fatty acids, and clinical response was associated with Akkermansia. Oh, and I must say, at 12 weeks, the effects had gone. So as soon as they stopped taking the fiber, they lost the beneficial effects. So again, continual intake of fiber seemed to be necessary to maintain the effects. A little bit about Akkermansia, interesting organism. Resides in the intestinal mucosal layer, produces acetate and propionate. It is linked with induction of PYY and GLP-1 and GLP-2. It is involved with cross-feeding with butyrate-producing bacteria, and it does improve barrier function. And this one trial showing just supplementation with Akkermansia in overweight and obese individuals showed an improvement in insulin sensitivity, again. So just as one organism did show a benefit. It also reduced systemic inflammation, had a small decrease in weight, and they did not see any significant changes in the gut microbiome. The same group went on to do further work, and they looked and they found that effects were linked to these increased molecules. And these are bioactive lipids that tend to act as endogenous activators of PPR gamma, or alpha. And they went on to show in animal models that they could use pasteurized Akkermansia to increase energy expenditure and also increase energy excretion. So again, there are mechanisms associated with specific organisms that we may use to treat patients. This is just some of the FMT clinical trials that have been done in patients with obesity and metabolic syndrome, a wide variety of conditions. Most have used nasal jejunal or capsules. They've used different comparisons, allogenic to autologous, and the results have been generally positive. There is one negative study, in 2020 in obesity, and interestingly, the one that was just published, they used a colonoscopy delivery, and I'm not sure why they chose to do that, because I think you need to have a small intestinal delivery for metabolic effects. And just to show you what happens with a small intestinal delivery, this study used a duodenal antireticulum infusion, and they could show that just putting one infusion into the duodenum increased GLP-1 and plasma secondary bile acids within 24 hours. And it was a double-blind, placebo-controlled crossover trial. So again, very rapid effects upon infusion of these compounds into the small intestine. Again, this is another interesting organism. It's an anaerobic gram-positive bacterium. It actually produces butyrate from lactate and acetate in an acidic environment, and subjects with insulin resistance are often characterized by this increased lactate production. So again, another promising candidate. Can FMT help with weight loss? Generally, no. There have not been trials showing effective weight loss with FMT. However, I just want to end with this kind of interesting trial design. So what they did was they took overweight, obese individuals, they enrolled them in a weight loss trial using 3 different kinds of diets for 6 months. And then after they all lost weight, and then they took the patients who lost weight, and then they prepared FMT from their own stools at their weight plateau. And then they went on and they divided them to either a placebo group or their own stool from when they had lost weight. And then they followed them for another 8 months. And what they found was that this one diet that is called the Green Mediterranean group, so it was a Mediterranean diet along with this green plant that was common in the area. And the subjects receiving the FMT from their own stools that had been on the Green Mediterranean diet maintained their weight loss. They maintained their metabolic benefits, and they had decreased levels of things like leptin, CRP, IL-6, and cholesterol. So again, this kind of suggests that specific changes in the gut microbiome are implicated in host metabolism and can be manipulated to provide benefit. And this is kind of a similar slide to what the others have shown. The challenges, there's a lot of conflicting data in the literature. Things like baseline insulin resistance, had a difference in our study. The metabolic background of donors, how do we choose donors? How do you measure their metabolic background? Small intestine versus colon. I think small intestine is very important for metabolism. Individual factors, transit time. Again, dietary intake is very important. Existing microbiota is important. Capsule, fresh or frozen, which is best. And again, beyond bacteria, looking at fungi, viruses, archaea. And just to end with key takeaways, I think that therapy aimed at microbiota-linked pathways have significant potential. And I think the strategies to use dietary strategies to enhance and maintain effects of FMT are necessary. I think we can use specific microbial components to stimulate GLP-1 secretion. And I think, again, talking about consortia and combining specific strains that have shown in human trials to have an effect and understanding some of the mechanisms from animal models can be combined to enhance metabolic health. And I will end there with my acknowledgments and to my collaborators. And thank you very much.
I think we have time for 1 or 2 questions. Back of the room there. Gianluca. And then front.
Yes. Oh, Gianluca Iania from Thank you for this amazing talk and for your great trial. I have two questions on the trial. The first one is very quick. Do the patients were on a controlled diet throughout the trial or not?
Did they? Oh, sorry.
And the second was, why, in your opinion, fermentable fibers did not achieve the engraftment, why non-fermentable did?
Okay, so the first question, did they control their diet? No. We asked them just to eat what you normally eat. So we monitored their diet before we started the intervention. We monitored their diet throughout the entire 6 weeks and the 6 to 12 weeks. And none of them changed their diet.
Okay,
so they all had very, very different diets. And why do I think the fermentable fiber didn't work? Is that the question?
On an ecological point of view. So why the engraftment was observed in a patient who received the non-fermentable fibers, while the people taking fermentable fibers did not engraft?
That's a very good question, and one we asked ourselves. Because when we broke the code, I mean, we were convinced that the ones showing effectiveness was going to be the high fermentable group. That was our initial hypothesis. And when we found out that it was a cellulose group, we were surprised, to put it mildly. And why it didn't, I don't know. To tell you the truth, we looked at all of the factors that we could think of. We looked at diet comparison between the different groups. We looked at medication use between the different groups. We looked at BMI. We looked at every factor we could think of to try to explain why it didn't ferment, why it didn't engraft. And at this point, I don't really have a good answer. I'm sorry.
Thanks.
Thanks a lot, Karine Clément, Paris. So, very nice overview. So I guess my question is a relationship between the gut microbiome and energy balance, because it can be seen as a paradox, because basically in the Gordon papers, the seminal papers already some years ago, clearly when you transfer gut microbiota from people with obesity or mouse with obesity to germ-free mice, okay, you can induce weight gain, right? So, but then when we look at what's going on with weight loss intervention or acting on the gut microbiome, as you clearly mentioned, there's no signal that this could induce weight loss. We more see improvement of metabolic condition. So my question is, so then the gut microbiome, this has nothing to do with energy balance? What is your view?
Yeah, so why did all of the early experiments in mice not translate into human? Yeah, if you look at the paper with the Akkermansia, they are starting to show that there is a change in energy expenditure, and they can increase excretion of calories, or whatever you want to call it, energy, with the Akkermansia. So it may be that it is you need certain conditions, certain bacteria to see that signal, and we're just not hitting it yet.
But when, in the Akkermansia paper, the first one you also mentioned, basically the effect on weight is so small. I mean, it's in the variability, right? It's more convinces, as you mentioned, for insulin or metabolic factors, eventually inflammation rather than weight per se.
Yeah, I mean, we're seeing this clear improvement in metabolic function without significant changes in weight. But a lot of these trials are like 6 weeks, which is not, a long period. So what we are wanting to do next is to expand that and take it out longer, because we could see that the patients, were starting to reduce their waist circumference in that 6-week period. So what if we take it out longer? Would we then see it? Are the trials just too short to see that? Thank you.
Thank you very much. And you can continue our conversations with our speakers over lunch. We'll rejoin at 2 o'clock back in the workshops. So thank you very much.